Hi, my name is Hunter Gray, and I'll be presenting our quality improvement project titled Reducing Double Phase CT Abdomen and Pelvis Imaging, completed at Stillwater Medical Center as part of our internal medicine residency program. I worked with this project alongside my co-resident, Dr. Doa Altamimi, PGY2, and we'd also like to thank our faculty advisor, Dr. William Anthony, as well as Dr. Tyson for their guidance and support. With the increasing use of CT imaging, we've seen clear benefits in faster diagnoses and improved treatment planning. However, CT scans expose patients to ionizing radiation, so appropriate utilization is essential. One area of concern is double phase CT abdomen and pelvis imaging, meaning scans performed both with and without contrast. This practice is tracked by the CMS OP10 quality metric and is often unnecessary for many clinical indications. Overuse not only increases radiation exposure, but also contributes to higher healthcare costs. The goal of our project was to identify overutilization of double phase CT imaging and evaluate interventions to reduce unnecessary use. Our objectives were to reduce unnecessary radiation exposure, promote high value imaging, improve adherence to evidence based guidelines, and reduce healthcare costs. We analyzed outpatient CT abdomen and pelvis orders with a total of 350 studies across 3 time periods. At baseline, from January to February 2025, we reviewed 71 scans and found a higher than desired rate of double phased imaging. We then implemented 2 interventions. The first intervention was provider education. We distributed a list of appropriate ICD-10 indications for double phased imaging to primary care and oncology clinics. These included conditions like neoplastic processes, infections, inflammatory conditions, and vascular abnormalities. After 3 months from March to May, we evaluated 142 scans and then introduced our second intervention. This was a quick reference guide that outlined body region, clinical indication, contrast type, and the recommended CT order. This guide was again distributed along with additional provider education. Finally, we assessed outcomes during the June to August period, which included 137 scans. Our primary outcome was the proportion of CT studies performed with and without contrast. At baseline, 11.3% of CT scans were double phased. After the first intervention, which was provider education alone, this increased to 15.5%. Following the second intervention, which included the structured quick reference guide, the rate did decrease to 10.9%. These differences were not statistically significant with a p-value of 0.26. However, the overall trend suggests that structural tools may be more effective than education alone in influencing provider behavior. Double phase CT imaging is often unnecessary and should be reserved for specific indications such as malignancy, infection, inflammation, or vascular pathology. Our study and project suggests that education alone is insufficient to reduce overutilization. More structured and accessible decision support tools may be necessary to drive meaningful change. Key limitations of our study include a relatively small sample size, short follow-up duration, variability in monthly scan volumes, and reliance on passive educational interventions. Moving forward, we believe more impactful change will require integration into clinical workflows. One proposed solution is incorporating decision support into the EMR. For example, linking appropriate indications directly to CT order sets and flagging or preventing inappropriate orders. Our long-term goal is to reduce double phase CT imaging rates to 5%, improving both patient safety and healthcare efficacy. Thank you for your time, and we greatly appreciate your interest in our project.